And I will have modified figures and tables from talks. This information is intended only for the educational lecture and is not to be further distributed. And I do have a slide of evidence-based medicine that includes several references from the last year, including the Vizara study of Tocilizumab that I'll talk to you about, as well as a review that we did on this topic, myself and Shoshana McMahon, in Arthritis Research and Therapy that I draw your attention to. So my goals for you at the end of this 25 minutes is to be able to recognize the importance of appropriately immunizing patients with autoimmune diseases. I'd like to really reinforce with you the different types of vaccinations that we have, especially those which are living organisms, as this has some relevance. And then we'll talk about the information that we have in the data concerning what our immunomodulatory therapies do to the responses to vaccines. We know that patients with underlying autoimmune diseases have an intrinsic increased risk of infection and an increased risk of serious infection, both from the disease itself as well as from the drugs that we use to treat. And we certainly know that immunizations have been quite effective in reducing immunization risk, and we see the effect of inadequate immunization with the outbreaks of diseases like recently in California. So I think that, especially in our patients, immunizations really have a significant role to play in terms of protection and reducing risk. We've talked for many years now about the window of opportunity in terms of treatment of patients with rheumatic diseases, or especially treatment of patients with rheumatoid arthritis, a window when we can achieve the optimal long-term outcome. And I'd like to propose to you that we also have a window of opportunity in immunizing our patients with rheumatic diseases that is really in that first encounter that we have with the patients and making an assessment and trying to induce the maximal immunological memory that will be with that patient for the long term. We know that immunizations are tremendously underused in rheumatic diseases. This is data from Jeff Curtis from 2006 that was looking at Medicare patients that included a large number, over 140,000 RA patients, as well as 770,000 OA patients, and evaluated the Medicare database to see how many patients had received a pneumococcal vaccination once in 5 years and an influenza vaccine as well. And the rates were really astounding. 84 to 89% were having good screening for hyperlipidemia over this period of time, but only 1/3 of the patients, and I remind you, these are all Medicare recipients that should have received a pneumococcal vaccination at least once in 5 years. Only 1/3 were receiving, and only 19 to 20% were receiving an influenza vaccine each year. Real-world data, real-world patients, and this is what's happening. So clear underutilization of the expected recommended vaccinations in patients with our diseases. When we think about immunizations and responses, it's important to think about the type of immunization that you're giving and what part of the immune system you may activate with that immunization. It's important to think about whether or not an immunization that you're giving is a neoimmunization, the first challenge to a patient to induce that primary immune response, or whether you're looking at an anamnestic response, a recall response, a booster response, as would be the case with something like herpes zoster vaccination for most people, where you're boosting the pre-existing memory with re-challenge. It's important also to understand that some bacteria and viruses are living organisms that are attenuated in strain, but these do have the potential for in being pathogenic in patients with immunosuppression. And then it's important to think about whether or not a vaccination is a protein, a polysaccharide, or a conjugate antigen in terms of the response that will be elicited and in terms of the cell types that are being activated. So people ask, what are the things that you can give without any problem? And this is that list. It's the things that we usually think about, tetanus vaccines, Tdap, hepatitis A and B, injectable forms of influenza, HPV. A lot of people don't know that HPV is actually is non-living and is a safe vaccination, inactivated polio, and then the conjugated pneumococcal and meningococcal vaccines. This is the list of the things for which you need to have some concern in patients who are immunosuppressed. Varicella zoster, we'll have a whole discussion on that by Dr. Calabrese next. Intranasal administration of influenza vaccinations, measles, mumps, rubella, and yellow fever. Those are sort of the top ones. But I'd like to draw your attention to the oral typhoid vaccine, the rotavirus vaccine that children may be receiving as part of routine immunizations, BCG in other parts of the world. And I do put down here a couple of things that might be of interest, especially. Dengue vaccines are in development and look like they may be relatively close, but most of those are living virus vaccines that are being tested right now. And rabies vaccinations in the United States, if you get bitten by something, are okay. But outside of the US, many of these are living virus vaccines as well. And then we have the carbohydrate or polysaccharide antigens that are T-cell independent responses, which may have some implications in using a B-cell directed therapy. And those include the pneumococcal polysaccharide, the 23-valent polysaccharide vaccination that we've all called Pneumovax, the meningococcus polysaccharide, and also a typhoid injectable formulation. So I draw your attention to the living virus and living organism vaccinations. And the reasons that I do this is because disseminated diseases have been reported in patients who are immunocompromised, with live living virus vaccinations especially. These cases have occurred in kids that are receiving their first varicella vaccination. Okay? And what has happened is that kids become sick, and that may be the first recognition of a child having an immunodeficiency syndrome. So that's one example where you have significant immunodeficiency and children becoming sick. And then also, there have been cases reported in patients who have severe HIV infection, severe chemotherapy, and organ transplantation with what should be an attenuated virus causing sickness and illness. What do we know about living viruses? There is very little data, but actually the data that we do get is summarized by the CDC that says that living virus may be shed for up to 3 weeks. And in the live virus vaccination studies that they've done in kids, they found that about 80% shed more than one strain, but the mean duration of shedding was 7.6 days. And then Dr. Calabrese will talk to us about zoster and recommendations in the next talk. So living virus vaccines are used in immunocompromised patients, and we do have some data to potentially help to guide you in terms of your patients. And one of those is the case of MMR vaccines in children. So MMR is a living virus vaccination, and routinely children with rheumatic diseases are presenting 2s and 3s and later in life. So what is happening, they have already received their primary MMR vaccines early on. But then those kids come in with JIA on methotrexate or etanercept and need to receive their booster immunizations for MMR. And in fact, this has been reported in small series, a series of 70 children with JIA on MMR and methotrexate who have received methotrexate or etanercept. What was observed is that none of the kids got sick, none of the kids have worsening of their arthritis. But it's critically important to recognize that these were booster vaccinations. These were not neo-immunizations. These were not primary immunizations, but they were boosting children's responses to what they had already seen. So presumably there was underlying immunological memory that was being boosted. Now we have a similar case with TNF antagonists with yellow fever vaccinations. So yellow fever vaccines for most of your patients who are traveling to other places in the world where this vaccine may be required are receiving a neo-immunization, the first time of exposure. And this information that I'm going to be talking to you about is not that case. Okay? This is a case of re-immunization with yellow fever vaccination in patients who are receiving TNF antagonists. So in Brazil, yellow fever is endemic in certain areas of the country, and routinely people are receiving re-immunization in those areas every 10 years. But there was an outbreak, an epidemic, where everyone was recommended to be revaccinated. And these investigators identified 15 patients who had been receiving Infliximab and received a yellow fever vaccination and reported on what happened. Now again, remember, these are patients who had been immunized in the past who were receiving a booster immunization. And what happened is that the serological responses were increasing appropriately in those patients. Infliximab did not affect the response itself. No untoward reactions were noted. But again, this is not to be extrapolated to someone who's coming in for a primary vaccine with yellow fever who's never seen it before. But we do have these two cases of people receiving booster vaccinations, and Dr. Calabrese, I'm sure, will talk to you about the case of TNF inhibitors looking at patients with zoster vaccinations as well. So what do we know from the drugs that we have in terms of immunization responses? I think what has really become apparent is that things that we wouldn't think that cause much of a problem or attenuate the immune response actually do when you study it. Vaccinations are not only a protective thing that we can do, but they actually tell us a tremendous amount about immune competence and about the ways that our drugs are acting on the immune system to tell us what is happening. And what has been shown recently with a number of studies is that methotrexate significantly attenuates the response to vaccination. So remember what I told you at the beginning. The time to immunize is early. The window of opportunity is short. That's because the data is beginning to tell us that methotrexate may blunt by up to 50% the responses that are seen to routine vaccinations. So if you want to immunize people, the best chance for primary immunization is before people go on to even methotrexate. Now, hydroxychloroquine has not shown to be a problem, but there are very few studies that have been done. Chloroquine has been looked at in malaria prophylaxis and didn't show any impairment of yellow fever response, but it did show that there was a decreased response to a living typhoid vaccination and to rabies vaccinations. So potentially, even though hydroxychloroquine has not been studied in as much detail, this information from chloroquine even suggests that responses may be blunted to primary immune responses. Leflunomide, we have very limited data, and the same with sulfasalazine. With other immunomodulators, azathioprine, mycophenolate, and cyclosporin, perhaps not surprisingly, what has been seen is a reduction in DTH responses, given that these are T-cell-directed therapies. And in most studies that have been done, while the immunization responses have been blunted, most patients are still able to mount protective responses with these drugs on board. Now, what about TNF antagonists and immunization responses? This has been reviewed by a number of different papers that have summarized the information that has looked at people who are receiving TNF inhibitors and the responses to routine immunizations for influenza, pneumococcus, and hepatitis B. While the results have been somewhat variable, I think that across all of these studies, it is very reasonable to conclude that while there may be a slight reduction in the responses to vaccinations that are seen in patients receiving TNF inhibitors, those responses remain present and they remain protective in most patients. So that's an important information. It says that just because someone is receiving a TNF inhibitor doesn't mean that you shouldn't immunize them. It means you should immunize them, but recognize that those responses may not be as high as they would otherwise have been expected. There is very limited data on live virus vaccinations. It's really been limited to booster responses, as I showed you with the yellow fever data. Studies on zoster are being initiated, and I hope that Dr. Calabrese will talk about that a little bit. If not, happy to talk to you in the discussion. Now, for Abatacept, we have a good bit of data that's emerged over time in looking at the responses to immunizations in people that are receiving this T-cell-directed therapy. Some of these studies have been done in healthy adults, some studies have been done in patients with rheumatoid arthritis, and some studies have been done in patients with psoriasis. And what we've seen is that there are slightly reduced responses with tetanus toxoid to recall responses with tetanus toxoid. When you look at the pneumococcal responses, either to the polysaccharide vaccination or to the conjugated vaccination, there seems to be a slight reduction in terms of the responses seen, and I'll go through a little bit of this data from the most recent study in a second. With influenza as well, there seems to be a maintained response. But in two studies that have looked at neoantigen immunization in patients with Abatacept, one looking at pandemic flu and one looking at KLH and Phi-X, there were significantly reduced responses seen in patients receiving Abatacept. In one of these patients, there was reduced seroprotection only achieved in 9% of patients on Abatacept, but in 58% in methotrexate and 69% in controls. So again, this would say that perhaps we should be concerned about neoimmunization in patients who are receiving some of our biological therapies. Now, this is the most recent study, and this has been being submitted for publication, but I'll present to you the information that we had in the abstract a couple of years ago. This was an open-label study of subcutaneous Abatacept in combination with background DMARDs. We looked at the polysaccharide, the Pneumovax responses with a twofold increase in titer in 3 of 5 antigens tested, and looked at 125 patients. These were 125 patients on background abatacept. 113 of these did not have protective titers at baseline. And among those who had non-protective titers, 73.9% of them mounted responses, 83.9% of which were protective. So again, with PPSV23 and people who did not have protection at baseline, there seemed to be a reasonable number of these patients who were responding. With influenza, this was also looking at the patients non-protective at baseline. 61% of those receiving abatacept achieved responses, 82% of which were protective. So again, this would say that at least in response to these 2 different antigens, that the response is present and most people protective with abatacept. Now, the limitation of this study is that there's no control group of patients who are receiving DMARDs alone. When we look at Rituximab, we actually have a good bit of data as well. In studies that have been done in lymphoma and renal failure, there have been reduced responses seen with tetanus, with polio, and with the neoantigen Phi-X. In small series in lupus, responses to pneumococcus and tetanus have been reduced. And in small series in RA, there has been a considerable amount of data to show that responses to influenza are considerably decreased in patients receiving Rituximab. Now, I'll show you the information from the clinical trial that we led that looked at a number of antigens in patients with receiving Rituximab. And the advantage to this study is that it actually did have a control group. The way the study was performed is that it looked at patients with rheumatoid arthritis. It randomized them to receive Rituximab in combination with methotrexate or methotrexate alone. And then 4 different things were administered to the patients. A tetanus toxoid vaccine to look at T-cell dependent responses, a Candida skin test to look at delayed type hypersensitivity responses, the Pneumovax to look at T-cell independent responses, and KLH to look at a neoantigen response. So in the patients who were receiving Rituximab, these immunizations were occurring at 6 months after the initial infusion. And this was 2 infusions up front, 1,000 times 2 with corticosteroids. In the methotrexate patients, just received the immunization, and then the responses were looked at. So what did we find from this study? This is the information looking at tetanus toxoid responses, a T-dependent antigen. So ideally, we'd see a 4-fold increase in titer on the left-hand side. And what you see is there really is not any significant attenuation with Rituximab. But this is the data that concerns me. Only 42% of the patients who were receiving methotrexate were mounting an appropriate response to tetanus toxoid. Now, when you looked at the T-independent or predominantly humoral responses with Pneumovax, you did see a difference with Rituximab. And what you saw is that there was about a 50% attenuation in the proportion of patients who were mounting responses to pneumococcal polysaccharide antigens. And this was seen really across the board with all levels of responses, and the same information was seen regardless of the serotype being tested. And when we looked at neoantigen responses in this study, we saw about a 50% attenuation in the responses in patients who were receiving Rituximab. So I remind you back to the data that we saw with abatacept with neoimmunizations being reduced. And again here, we're seeing neoantigen responses being reduced in patients who are receiving Rituximab. But really with methotrexate in this circumstance, there was not a significant effect on that neoantigen response. And then DTH responses, which would be predominantly T-cell mediated, there was no effect of patients who were receiving Rituximab compared with methotrexate. So we've talked a little bit, and I heard from earlier lectures today, moving us into thinking about BLYS and BAFF. The information that we have for these compounds on immunizations is quite limited at this point. There was a study done in lupus, the BLYS 76 study, that reported on the patients who maintained titers of routine immunizations with pneumococcus or tetanus over the preceding 5 years. And there wasn't any drop in their titers over the course of the study. And in those few patients who had received an influenza vaccination, they did look at responses there, but the numbers were very small and but there didn't appear to be a change. Now, data with Tofacitinib, this is another anti-BLYS-BAFF pathway agent. This was being looked at and studied in rheumatoid arthritis. Those studies were terminated for lack of efficacy like we saw as well with the belimumab and rheumatoid arthritis development program. But nonetheless, nested within one of these large studies with tofacitinib was a vaccination substudy. And those results have been submitted for review, and we hope that we'll be able to report out on that information in the near future to you, and those results are pending. So we have another controlled clinical trial that looked at tocilizumab in responses with this drug. Now, I was involved in the study design for this, and it's not the optimal study design, but it's better than nothing. Because I would have wanted to look at patients who were receiving tocilizumab for a period of time, where you might have some effect on Th17 cells and other aspects of innate immunity and other responses that we really don't know anything about. But oftentimes these decisions are driven by regulatory concerns and the minimum requirements of information that you need. So this is what we got out of this study. It was basically patients who were receiving tocilizumab or methotrexate versus methotrexate alone. They were randomized at the beginning with similar characteristics of the two patient populations. In the tocilizumab patients, they received two infusions of the tocilizumab and received their immunizations 3 weeks after the first infusion. And then the responses were measured 5 weeks afterwards. And that was the primary endpoint, was looking at pneumococcal polysaccharide responses. And when you looked here, the primary endpoint that's highlighted, there's not a statistically significant difference between these two groups. There is numerically a reduction in the responses with those on tocilizumab with methotrexate compared with methotrexate alone across the board, but you see the widely overlapping confidence intervals. And when you looked at the information regarding tetanus toxoid, again, here's the information with methotrexate that was so disturbing. Only 39% of patients on methotrexate were having appropriate responses to tetanus toxoid immunizations. But the tocilizumab addition did not appear to cause any change in this. Now, we didn't have information in this study on neoimmunizations. We didn't have information in the study in patients who had been receiving long-term exposure to tocilizumab, but I think that what we conclude from this is, at least with short-term exposure, there does not appear to be a significant impairment of responses to these two common antigens that are being tested. We do have recent data from tofacitinib that was published in the last month, in this Winthrop reference down at the bottom. This was information from 2 different clinical trials with tofacitinib. The first was a control study with 10 milligrams twice a day of tofacitinib, larger than the actual approved dose for this drug, versus placebo, and patients were stratified for whether or not they were receiving methotrexate. They received influenza vaccinations and they received the pneumococcus vaccinations, the polysaccharide. And then responses were looked at 35 days later. Here is the overall information. The patients receiving placebo, meaning methotrexate in the background, versus all the patients on tofacitinib receiving methotrexate as well in the background. And what you saw when you looked at the overall population was that there was a reduction in the pneumococcal polysaccharide vaccination responses, but there wasn't an effect on the influenza. But I told you that the results were stratified based on methotrexate dosing, or on methotrexate receipt. And here is the information when you looked at that. In the patients who were receiving tofacitinib monotherapy, there really was not a reduction at all in terms of that response to pneumococcal polysaccharide. It was the addition of the methotrexate in this case that seemed to make the difference. So again, this information about what is the role of methotrexate in terms of responses, I think we need to be very, very concerned about and think hard about in understanding that our patients who receive any immunization on methotrexate may have suboptimal protection. Doesn't mean that it's not going to be there, but it may be suboptimal. And then the second study was asking a question. If I have a patient who is receiving tofacitinib, do I need to hold the tofacitinib in order to give them the vaccination, or can I continue administering the tofacitinib and give the vaccination? Will it make a difference? Continuous versus interrupted therapy. And again, the pneumococcal is looking on the left, and the first bar that you see is the continuously administered tofacitinib and methotrexate. Now, if you go over to the green bar, you see the tofacitinib and methotrexate interruption there is a little bit of an increase in response. Now, but in those patients who are receiving the tofacitinib monotherapy, which is the blue bar, going to the interrupted therapy, holding the tofacitinib, there really is not a significant response in terms of the pneumococcal antigen. And you really don't see a difference at all when you look at the influenza responses. So again, this issue related to methotrexate seems to be important. Now, putting it all together, I'm going to draw you to a slide that is actually taken from this paper in Arthritis Research and Therapy that we recently published. We've summarized all of the data that we were able to get to and put it together in a tabular form across the drugs that we have. Information that I didn't present to you here is actually from ustekinumab. There is limited data for this, but it does appear that there is no effect of ustekinumab on responses to protein or carbohydrate vaccinations. But with all of these, this is sort of your easy-to-use chart in terms of looking at these things. I will draw your attention to a couple of very important websites from the CDC. The first is their vaccine website, cdc.gov/vaccines, and the second is cdc.gov/travel. If you have a patient who's traveling to an area, the travel recommendations, you can put in the country that the patient is going to, and you can tick a box that says your patient is immunocompromised. And you'll get all of the CDC recommendations regarding immunizations and regarding risks related to those for your specific patients. Very, very useful information if you don't have an infectious disease consult available, and actually sometimes better than the infectious disease consults that you might get. But I wanted to close in talking about one additional recommendation from the CDC. And these are not new recommendations. These are recommendations made in 2012 for all adults over age 19 with an immunocompromising condition or immunomodulatory therapy regarding the use of the conjugated pneumococcal vaccination. So the conjugated vaccination became available in the United States a couple of years ago. And again, the polysaccharide vaccination, remember, is only activating T-cell independent responses. The conjugated vaccine brings in the T-cell, may give you a more robust response and longer lasting memory. The recommendations are that in people who have not received a pneumococcal vaccination, they should receive the conjugate, PCV13, and then at least 8 weeks later, they should receive the PPSV23, and then every 5 years thereafter. In people who have previously received a pneumovax, if it's been more than a year since the pneumovax, you should give them the conjugated vaccine and then resume the every 5-year therapy with the pneumococcal polysaccharide vaccination. So these have also been incorporated in recent guidelines from the Infectious Disease Society, which says, again, this 2-vaccine combo is recommended in the immunosuppressed. It does recommend that a live virus vaccine can be given to patients without varicella immunity 4 weeks or more before the initiation of immunosuppression. Remember, I told you that sort of that live virus, how long is it going to be around? Probably 3 to 4 weeks. So this is the 4-week time point that they've said. And zoster vaccine, which Dr. Calabrese will talk about next, again, with those recommendations. Down at the bottom, I think it's very important in terms of the bolded things. An immunocompromised person on therapy should avoid contact with a household member who develops a rash after the varicella or zoster vaccine until the lesions go away. And the key is in someone who might develop a rash to that vaccination. Otherwise, there's not a risk of transmission. But here's another one that I was unaware of. Rotavirus, given to children routinely as a vaccination, is shed into the stool, so changing diapers is actually not recommended for at least 4 weeks for someone who is immunocompromised if the child has received a rotavirus vaccination. So my suggestions for immunization, and we've started doing this with everyone at their first visit, taking an immunization history, documenting this, and trying to ensure that we can optimally immunize patients at the very beginning. Helping patients to understand the importance of these immunizations and really coming up with a plan that's going to be with the primary care provider in terms of who is going to be what, who is going to be doing what, and when, and how. And that there really needs to be an ongoing assessment and discussion in your patients. So the immunizations, I believe, are very important for our patients. Our therapies pretty much across the board have some attenuation of responses that we need to consider. That means that perhaps if you give somebody a zoster vaccine who is on background methotrexate, as the CDC has said is okay, that vaccine might not work too well. Okay, how do I know this? I've had 2 cases of patients who've gotten exactly that, and then what do they get? They're on their TNF inhibitor after that, and then they've come down with zoster. So our vaccines are not working that well in our patients, but they're always probably better than nothing at all. Thank you very much, and I will take questions at the discussion.